He has been Saskatchewan's Provincial Chief Medical Health Officer, and in the past he's worked as a Regional Medical Health Officer as well as an internationally renowned internist, faculty at the School of Public Health, and a public health expert with multilateral health and donor agencies. So very, very busy and very, very accomplished. He is a past co-chair of the Pan-Canadian Public Health Network Council, a past chair of the Medical Health Officers Councils of Saskatchewan, and past president of the Saskatchewan Public Health Association. Dr. Shahab is a fellow in public health and preventative medicine at the Royal College of Physicians of Canada, and he has a Master's of Public Health from Johns Hopkins University and is a member of the Royal College of Physicians, United Kingdom. So, Dr. Shahab, welcome. Thank you for taking the time out. I know this could not have been, as we saw the news coming up, we're like, is this going to be possible? What is our plan B if Dr. Shahab has to make a quick exit? So please know how deeply appreciative we are in this very, very busy time that you could come and speak to, which I didn't mention. We have well over 200 registrants for Research Showcase this year. So without any further ado, thank you, Dr. Shahab, and I'll turn the presentation over to you.
Thank you. I'll just maybe start sharing my PowerPoint, and I should have actually attended the training session yesterday so that I wouldn't waste everyone's time trying to do this, but let's see. So can everyone see my slide set?
Yes.
Yes.
Okay. And I don't know, I'm assuming colleagues who want to can see both me and the slide set. Is that how it works?
Sorry, could you repeat that question, Dr. Shahab?
I'm assuming you can see both me and the slide set in terms of what your settings are, so that I will just move the slide set and that should be fine.
Yeah, we can see you and we can see your slides. I'm going to ask IT if you can hear me, if you could minimize the other or make Dr. Shahab a bit bigger, that would be great. But I see you on my screen.
Okay, that's great.
And your slides.
Okay, so so I'll maybe begin and I'll maybe speak for about 20 to 25 minutes, and then, but I do want this to be an engaged, interactive session. Certainly, I'm looking for good ideas from everyone on this call, and that is what working in Saskatchewan is about, and that is what today is about. I know when I was asked to speak to this, and Randy contacted me, I think late August, early September, I said yes very quickly because I thought, yeah, sure, we'll just talk about how well we've done in Saskatchewan and Canada, and that'll be that. But that was then, and we are in a very different situation now. So again, I want to emphasize that please, put forward, like was mentioned by Elan, put forward your questions and comments, and I do hope to maybe stop at the end for some discussion. So I just want to confirm we have about, how long do we have in total for this? About 45 minutes?
We've got 45 in total, and we saved, so anywhere 30 minutes is great. Take a little bit longer, but we've got 45 minutes, including questions.
Sure. So I'll try to stop before 30 minutes because I do want to have a bit of an interactive discussion and frank discussion on these issues. So, I do want to start by acknowledging, first of all, the people of Saskatchewan. I think this pandemic, just like any other issues we have, it does show how we pull together. And for the pandemic, actually, it shows how we have pulled together while staying apart. And this conference, again, is a great example of, active participation in a situation where we can't be face to face. I also want to acknowledge, my colleagues in Saskatchewan, medical health officers and public health teams who've been working flat out for the last 9 months, 10 months. Obviously, Saskatchewan Health Authority, I think we as a government and Saskatchewan Health Authority are facing our first true test as a single health authority. And of course, partners in universities in Saskatchewan, University of Regina, University of Saskatchewan, especially, the group doing modeling and science review. Government of Saskatchewan, obviously, not just the Ministry of Health, but the entire government has been involved in the pandemic response because that is what pandemics need. They need a health response that is critical, but also an all of government response that has to be aligned with the all of society response. And of course, a lot of our evidence-based actions are based on information we generate within Saskatchewan, real-time information, but also are based on national and international information. And so the Public Health Agency of Canada and all my colleagues in the province and territories, I think, have been integral for the Canadian pandemic response. And again, we are at a very dynamic stage. So obviously, I'll be walking through how we got here, and then do want to spend some time about what I see potentially happening in the future. But obviously, we can't predict the future. All we can do is, try to make our best assessment of where we are going and what we need to do to minimize the impacts of the pandemic. So I just start off by saying, just sharing some links that I saw yesterday that really speak to, real-time research informing policy and response. And again, some of the links I think speak to the posters, the presentations, and other information that, Sheriff has showcased. And this really speaks to the fact that, real-time research is important, as is research that develops over time. Generally people obviously have a career based on researching specific areas, but this just shows that researchers with many years of accomplishment have been able to pivot to address COVID-related issues in a very broad way. It relates some basic research, around vaccines that Vido's been doing, basic clinical research around testing platforms that, the RRPL, Royal Rubber Provincial Lab, along with the SHA has been doing, to deploying, new initiatives around testing, contact tracing, communications to the public. I think a lot of this is not just basic research, but also applied research and evaluation. And I think this just speaks to how accomplished researchers can pivot to address questions related to the pandemic in real time. And that just speaks to our flexibility and cohesion as partners in Saskatchewan. I'll maybe speak to where we have come so far, but then also maybe look forward to your ideas, and I hope the chat can be saved and shared afterwards with me, at least, that if you have ideas about how research can inform policy in a better way, and how policy can continue to inform the research agenda. And we already do that, 24/7, but how can we improve some of that? Because certainly we are not out of the pandemic yet. And obviously this is just one pandemic, but I think it's built on a strong bedrock of collaboration between research and policy and delivery of healthcare services and public health services. So, I think most of us are aware of the history, but I'll just walk through that. December 2019, through ProMed and other channels and through the Public Health Agency, we were hearing about a cluster related to the live animal market in Wuhan, China, and there had been several dozen severe pneumonias linked to that, and no fatalities at that time. So we routinely get these kind of alerts and obviously pay attention to them, because public health has a very active travel program, travel medicine program. And so a lot of this information is used to advise travelers or to watch for signs in case of people coming back. And then, of course, in January, the World Health Organization formally announced a significant cluster where it was becoming clear that there is human-to-human transmission happening. Obviously, whenever you see something like was seen in December, that's the tip of the iceberg. So it was severe pneumonia, in some cases leading to hospitalization and death. But again, very quickly, teams in Wuhan, along with the World Health Organization, and increasingly in international partnerships, were describing in real time, the presentation of the illness from mild to severe, impacts by age group and comorbidity, incubation period, infectious period. And of course, by January 11th, which I find quite remarkable actually, is that the genetic sequence was shared. And already on January 10th, I think the UK had developed a test based on what they knew at that time. But by January 11th, the genetic sequence was shared, and the international community was developing tests for platforms for testing the virus. So again, it speaks to how quickly things move. Like within 2 to 3 weeks, there's already genetic sequence available, and applied epi happening on cases as they were presenting. So by late January, early February, obviously, the big question was, can it be contained? Can it be put back in the box like SARS was put in the box in 2003? So as you know, SARS was a coronavirus that had ultimately a 10% mortality. It impacted China, but then several other jurisdictions, including Canada. It did transmit better the more a person was symptomatic. And so public health measures were used with great effort to contain SARS, and within 8 to 9 months, SARS vanished from, in terms of a pathogen of concern. So that was specifically around the transmission criteria of SARS. And so that was the first question, can it be put in the box like SARS? Obviously, MERS is another coronavirus that has a higher case fatality. It's about 30% compared to 10% for SARS. But it has been, sputtering along since 2012. But for a variety of reasons, it hasn't taken off as a pandemic. So again, the question was that, everyone's hoping it'll be something like SARS that can be contained. But very quickly, data was emerging again from primarily Wuhan, that there is asymptomatic transmission, especially in younger people and children. There was a case study about a child, 12-year-old, who, along with his family, tested positive, but was asymptomatic, even though there was some radiological evidence of pulmonary involvement as well. And it was also emerging that you can also have pre-symptomatic transmission. So very quickly it became obvious that this will not be something that will be as easy to manage as SARS, because you have transmission that happens before symptoms. So then the question was about transmissibility. Is it going to be as bad as influenza, or even worse? And then by now we know that transmissibility is in between influenza and measles. So it's actually more transmissible than influenza, especially because of the asymptomatic transmission. And of course, that in some situations there's a whole spectrum of transmission, from contact and fomites and droplets, but also aerosols as they're generated. So obviously, at the same time as we in Canada and Saskatchewan and the rest of the world were preparing for managing individuals in the healthcare environment, there's a tremendous push for ensuring all of us have the appropriate PPE. So infection prevention control guidelines were developed. ERs in Saskatchewan were on alert to ask for travel history and isolate individuals with the travel history. And so that already started in February. The testing platform was established in Saskatchewan, and initial discussion on therapeutics were emerging. Obviously, with the coronavirus, the bulk of the management is symptomatic, but obviously very rapidly. And I won't talk too much about that, but the therapeutic experience, both in terms of ICU management and use of dexamethasone and other treatment modalities, has been expanded, and of course all clinical trials, all treatments with other interventions, you had to be enrolled in an international trial, so that in real time you could see what's effective and what's not. So I think that was again something that came together very quickly in February. By March, obviously, we had our first case in March, but Canada already had started seeing sporadic cases in February. And so had the US. And of course, we were watching very closely what was happening by that time in Northern Italy, significant pressure on the healthcare system in Northern Italy, and then emerging pressures in New York City, for example. So by that time, it became apparent that even though we were seeing only sporadic cases in Canada, we knew that this would not be something that would be contained. And I think that was a significant policy shift from containment to mitigation. Excuse me. So it just had to, suppress a sneeze there. So sorry about that. So I think this was quite a different. This was first or second week of March. There was a major shift from containment to mitigation, and what that meant was that we are definitely in for the long haul. the WHO obviously announced that we are in a global pandemic. And it meant that, this is a marathon, not a sprint. This is not something SARS took about 12 to 14 months to put back into the box. But by that time, we knew that this certainly is not going to be like SARS. It's going to be much more significant, much more global. And this will really continue for a longer time. And this may become something that just becomes a coronavirus that then is part of the coronaviruses that go around, or maybe ultimately through a vaccine or other measures, it may be suppressed ultimately, but certainly not earlier than a year. And obviously, from acute care and ICU capacity, the ramp up had to be significant because it was a global pandemic, as well as what the public health measures should be. And this is when, Canada, including Saskatchewan and most countries in the world, entered into a broad lockdown, something that we always planned for, but, many of us actually, never thought that we would see something that dramatic happening in a lifetime. All international travel, 95% plus seized globally, and we all saw, the lockdown in terms of non-essential workplaces, non-essential retail, restaurants and bars. And then we then started, obviously doing our public health measures, including testing and contact tracing and monitoring as cases rise. Will we see secondary transmission in Canada? So as you can see on this slide, very quickly in March, we saw our first case, and we went into slowdowns for public gatherings, but then very quickly into lockdowns. If you recall, late February, there was a plan to have Junos in Saskatchewan. The first week of March, they were cancelled, and by third week of March, we had our first death due to COVID-19, and we really were into a sustained lockdown for. At that time, we weren't sure how long that would last, but certainly we were looking at it for at least a few weeks. And obviously the health system was gearing up, including screening for staff and visitors and other measures. And of course, there were some travel restrictions as well for the North because of concerns about COVID reaching the North as well. So that was what is happening in April. And then if you look at, and I apologize for these slides, there were many of them were put up from reports, over the last couple of days. So I apologize that they're not as sleek as they could have been. But if you look at our cases in March, the bulk were international travel, and quarantine was put in effect. So the secondary transmission primarily was to household contacts or close contacts of people who had traveled internationally. And most of our cases were from the US, Europe, and a few other countries in terms of where people had been returning from. And of course, there was a call for Canadians to come home. So many people who go south for the winter, for example, were coming home. So the bulk of our cases at that time were international travel, but also, some interprovincial travel, obviously from provinces that were seeing a higher case load than we were because of greater international travel or receipt of international arrivals. So April now, we had learned that actually we were starting to seeing community transmission. Our testing platform had expanded to include people in Saskatchewan who had fever, cough. Our test positive rate was around 1%. But we were seeing that on the one hand, there was community transmission. Regina and Saskatoon primarily did see quite a significant increase in cases, both due to international travel, secondary transmission of the household, but also increasingly transmission in the community setting. So, and then there were some clusters in Lloydminster, for example, other parts, North Battleford, PA. So there were some transmission events related to in March, before lockdown had come into an effect due to curling bonspiels, to socialization around meals, for example, after a ski-doo rally. So we were seeing transmission events, but we were also seeing that the dynamics were such that you could actually prevent them to a large extent by lockdown. And of course, testing and contact tracing was expanding. The testing capacity was expanding. The contact tracing capacity is expanding and becoming more focused on high risk settings as well, including group events or social gatherings as well. Just check time. So I think I have about 10-15 minutes more. So I'll try to wrap up in about 10 minutes. So May to August, I think we had learned quite a bit about transmission and how it can be managed with everyone's cooperation, and I think we have to also recognize that Saskatchewan, the way work is in Saskatchewan, there's agriculture, there's other essential industries, and then there's a corporate sector, there's office-based environments. There's obviously retail, restaurants, and then there's recreation. So the reopen plan recognized that a large proportion of people actually had remained in work throughout because they were part of essential work, and they had kept our grocery stores open. Staff had kept our supply chains intact. We didn't see a lot of the shortages other parts of the world were seeing. So again, recognizing all the frontline staff, healthcare, essential services, who really continued to work in a safe manner, for the most part, avoided transmission events in those settings. And we also, then were confident that we could safely reopen. And all provinces had their reopen plans that were, somewhat different from each other. And again, as we reopened from May to August, some people thought we were reopening too quickly, some thought too slowly. But we did reopen safely, and what we saw was that we did not see a significant increase in transmission as those sectors reopened with quite clear guidelines that were part of the Reopen Saskatchewan plan. We did, however, at this point see localized clusters and outbreaks. We saw a sustained outbreak in the Northwest that again, leaders in the Northwest, public health teams, the SHA really provided significant surge support. And I won't go into details because I see there's a presentation later today after 11 on that, but that was really showed us how even in challenging circumstances, you can get ahead of a complex community-based outbreak. And then we saw other localized clusters and outbreak in community living settings. And we also realized based on the evidence and the science that outdoors is better. So we were quite confident that whatever we did outdoors, maintaining some physical distancing between households would really not be a problem. And that's what we saw as we started enjoying the outdoors in our great, Saskatchewan summer. And here you can see how the reopening happened through May, June. And we managed to maintain a flat curve. And a lot of the increase in cases that you see towards July and August were really mostly due to localized clusters in the northwest of Saskatchewan or other parts of Saskatchewan. And we did not see a sustained increase in transmission. And we saw some travel-related cases linked to less so to international travel, but mostly interprovincial travel, primarily due to work. And then this slide just shows that the light green is the international travel that has kept going for the most part, but till October, a lot of the spikes were basically due to localized outbreaks. And I would submit that, we didn't really see a true wave in Saskatchewan that some other jurisdictions in Canada had seen. Our numbers overall are fairly low. Our acute care and hospital and ICU hospitalizations are also fairly low. I think generally between 0 to 15 on any given week. August, since June, we had been working on a very significant sector, the school reopening plan. And I think that's where, a lot of work was done in June, July. There's a lot of evidence reviews at that time that are available through, international partners, as well as the Ontario Sick Kids report. But based on learnings from, for example, other parts of the world, Europe, Scandinavian countries, Israel, there were some concerns emerging about school reopening, that will there be small clusters, will there be significant outbreaks? So our school reopening plans were again revised in August and early part of September. And again, this showed the application of real-time research where, I know there's a transmission by Dr. Groot later today, but, we had not been accessing from the public health side, or certainly from the government side, a lot of the resources around the evidence reviews. I know that there have been a lot of support provided to in terms of clinical management throughout the pandemic, but then we really started reaching out our colleagues in the UFS, the evidence review group, and we rapidly got many documents that informed our school reopening. And I've just put together a couple of links, but I think the presentation today has a link to the entire body of evidence review. And this was really useful because while we had international reports and evidence reviews, the evidence reviews done by University of Saskatchewan really contextually relevant for us, and really, we would have policy meetings that were attended by people within government, colleagues within public health, SHA, and the University of Saskatchewan, and that common table I think was essential in order to distill what we could put in place that was feasible for our environments. Northern remote schools, First Nation schools, urban schools, schools that were fairly small, K to 12, versus high schools that are very large. So that really led to, for example, 4 levels for school reopening. And as you can see, just this last week, we actually recommended that all larger high schools go to level 3. So we are now actually applying some of the proposals that were formed in August, September, in terms of if transmission goes up, what specific steps need to be taken. Just taking the time here. Now, October, of course, was, most people had been predicting throughout the world that, and obviously Australia, South Africa, they had seen their winter and their surges over their winter over July, August. Australia had seen a very mild influenza season, but significant surges that they had managed very aggressively. South Africa had seen surges, and so did parts of South America and many other parts of the world. So there was an expectation or a prediction that we will see a second wave in the fall. Many places had, in the UK, for example, had already put in place many lockdowns which by our standards would be very large cities like Leicester, a few 100,000 people. And so we already had seen that there could be an increase in the fall, and we need to be prepared with localized measures or broad measures. And through October, we already were doing that as we started seeing increase in cases, initially through super spreader events related to nightclubs, and in one case, a worship event. And then there were change in public health orders to not allow some of those, and some significant fines that were issued. But then increasingly, we start seeing increased clusters, small clusters in workplaces, and all kinds of settings that were under the reopen plan. So we could see that the community transmission pressure is going up, and our population mixing obviously is going up. So we started messaging that gathering sizes in the home went down from 30 to 15, especially because you couldn't have them outdoors. They've gone down to 10. And now receptions outdoors, in other places, in public places, can still be up to 30, but with strict protocols. But we are, there were tightening of some COVID guidelines. Excuse me. But we already could see that we are heading in the wrong direction in Canada and also in Saskatchewan. And so we had to start getting ready for what could happen in the ensuing weeks and what our strategies would be. So as you can see here, we are now in our first true sustained wave, and this just shows till 6 November. But what we can see over end of October, November is really our first true sustained wave, and primarily due to community transmission throughout Saskatchewan. Initially, it was mostly in Regina, Saskatoon, PA, end October, early November. But now, if you go to our dashboard, you can see we have high active cases throughout Saskatchewan. So now we do have sustained community transmission throughout the province. So obviously, there's kind of 3 kind of buckets. There's the SHA offensive strategy, testing and contact tracing. So the testing platform is very robust. There's some challenges with reporting test results in a timely way, but they are being addressed. Contact tracing again is coming under a lot of pressure because not only are the cases rising, but number of contacts between 5 to 8 per person are rising, and in some cases, there can be many contacts. So again, that's coming under pressure. And obviously our hospitalization has gone up from bed census of 10, 15 a day to now higher than 50, with about 35 people in hospital, 10 to 15 people in ICU. Unfortunately, deaths are going up as well. We haven't seen the large outbreaks that other provinces saw in long-term care and personal care homes that causes a very high mortality, but we are seeing increasing cases in long-term care and personal care homes. So that again is going to be a big concern in terms of the pressure that puts in terms of unfortunate mortality and also hospitalization and inpatient care. So November is going to be a busy month for us in terms of what do we need to do, and we've been putting in some tightening measures throughout, if you see on the right side of the slide. But I think the big question for us in Saskatchewan and for the country is going to be: do we further tighten, in reverse order to the lockdown or to the reopening, or do we go into a fairly strict lockdown? And again, obviously there are views on both sides. Physicians have written to the government, and not just in Saskatchewan, other provinces. We're watching very closely what's happening in other parts of Canada as well. But I think there'll have to be some significant decisions made over the next couple of weeks, policy decisions that are informed by the evidence. And ultimately, we'll have to see. It's been very difficult, and this is again for our colleagues who are on the call. It's been very difficult in real time to evaluate which measure has what impact. You need a week or two to see an impact, and then the attributable fraction of a measure. What happens if you slow down sports teams? What happens if you slow down restaurants and bars? Certainly, we've seen that we aren't seeing super spreader events because specific measures put in place in 2 weeks ago, and that's great. But beyond that, I think that's an area of applied research that really it will be useful to see that, how do you adjust the three dials, the offensive strategy, defensive strategy, and the public health measures, and the modeling group uses that term, the three dials, in terms of how do you modulate all three so that you get the minimum COVID transmission with minimum societal impact. And I know some people will say that we have to control cases at all costs, but I think there is a societal impact, not just economic, but mental health and societal. And I think because this is something that we'll certainly have to see for the next few months, when do you apply measures, how strong, how sustained? I think it's going to be questions that we will have to address over the next couple of weeks, certainly, but ongoing throughout our fall, winter, and spring. And this is just and it's been astounding to see how, there's lots of dashboards where you can get data. This is just something I downloaded this morning and for some reason the US has vanished, but there's obviously China that has had very stringent measures and very broad testing and is here. South Korea has done very significant testing and contact tracing, universal adoption of a contact tracing app, backward contact tracing, for example, and they have done pretty well, as have many Southeast Asian countries, including Australia. Canada was in quite a comfortable position, much below the US and much below many European countries. But you can see now that Canada is now trending up. And in fact, if you go to, I used to go to a dashboard which showed all the Canadian provinces and territories are below all US states, but now all Canadian provinces and territories or many of them are actually in the middle or more than a third of the US states. So certainly, we are moving up in terms of our ranking, in terms of cases per 100,000 or active cases per 100,000. And this is again downloaded this morning that for me, looking at cumulative cases is not useful. I look at rates of new cases averaged over a week, or in this case, rate of active cases. And this is just from this morning that, over the summer, we were pretty flat. Manitoba is even flatter than us. Now, of course, Manitoba has the highest number of active cases, followed by Alberta, Quebec, and we are number 4 now. Nationally, we were slightly below BC 2 weeks ago, but we have overtaken BC. So certainly we are the 4th highest in terms of active cases as of today. But what we are going to do about it, I think, is going to be based on, where's transmission happening. So again, it's happening in household settings, in small gatherings, even under 10, but also in all settings that we enjoy, playing sports, even though there's guidelines around that, going to a bar or restaurant, even though there's strict guidelines around that, at workplaces, even though workplaces may have strict protocols when you're at work, but during break times, carpooling to work, all those layers have to be in place. Schools have seen, a significant number of single cases reflecting community transmission, very few outbreaks, and if that, minimal transmission within the school, if there's been 2 or 3 cases, but as a precaution measure, larger high schools already are going to level 3. But what further slowdowns need to happen, what further lockdowns need to be happen. I think there's going to be important discussion in the next 2 weeks. And as you can see, we had a up and down sawtooth pattern for the first part of the year, but this is a first true wave. I think some other jurisdictions in Canada did see a significant wave in the spring. We didn't see that province-wide. So this is really our first true test on the pandemic in terms of sustained community transmission. There's been lots of discussion nationally around, what impact will the Christmas holidays have? Will it give some respite, especially for schools? Will it create a surge if there's lots of family gatherings? The term circuit breaker was used in Britain about a sharp lockdown for 2 to 3 weeks to halt community transmission with some economic impact, but at least you can come out of it in 2 or 3 weeks. So I think this will be a discussion for us also, that how do we put in sharp lockdowns, for how long, for what sectors, and how will we know if that's having an impact? And we have to remember that all this has to be built upon a bedrock of individual behaviors. And I know there's some ongoing commentary about that we need clear orders, but all of this does build on individual behaviors. And I did say right in the beginning in March that you can't police your way out of a pandemic. And what we saw in March was actually, even though you could get together in groups of 10, people are not getting together, even though it was allowed. But now that we're entering into a first sustained wave, the question is, will people actually be as diligent with maintaining that physical distance, mask use, not having any gatherings outside the household? So I think that's going to be key decision point for December. And then January to March, and I'll finish in about 3-4 minutes. January to March, I think is going to be, there's going to be a vaccine available likely, but we'll wait to see when it's going to be available, how much is going to be available, and who the priority groups are. Chances are that, obviously it will be for people who are at high risk in terms of morbidity and mortality, and limited amounts will be available in Canada and many other parts of the world in the later part of the winter. March to September, obviously, how will the vaccine pipeline flow? And again, 2 vaccines have announced 95% efficacy in initial trials, but what is the pipeline for those 2 vaccines and other pipelines? What will be the impact of school break in the summer and the fact that it will be outdoors more? So again, I think April onwards, I think we will get some respite from the pandemic due to a variety of factors. You can be outdoors, the school break, there's more and more people getting vaccinated. And then, of course, I heard of a quote from someone who works in the US CDC who, because they still measure distance in miles, they said that today, right now we're on mile 10 of a 26-mile marathon. So, which for us, but I could have said, 15 kilometer of a 40 kilometer marathon, but the mile analogy was good because we're in the 10th month. But, certainly, is this something we will not come out of for about 2 years? I think is a big question mark. I think there's some comments being made by the vaccine experts that maybe, if you get a high enough vaccination rate with a very effective vaccine, we may see a fall winter that maybe not as severe as this in terms of COVID. If there's a high uptake of a very effective vaccine. I think prior to this, we were very cautious because we had thought if the vaccine availability is limited till as late as February 2022 for the majority of the population, and vaccine effectiveness is about 50% with unknown long-term immunity. We do have to be cautious about the impact of vaccine on the pandemic. But obviously, if vaccine effectiveness is higher, availability is better through 2021, and protection is longer than just a few months, the next fall, winter may be less significant in terms of COVID risk and precautions we have to take, that we have to take now. So I think this is going to be where we will know more about in the spring and the summer. And then I didn't put in a lot of references, but certainly the WHO has a nice timeline that speaks to how things have developed till now. But obviously, we are still in the middle of the pandemic, and I would say that we are now in our most challenging time ever. So with that, I'll maybe stop and then open it up or hand back to Elan for some discussions. Thanks.
Great. Thank you so much, Dr. Shahab. We are opening up the chat box here. So if you have any questions, please populate them now. And if possible, we will unmute you. And in the meantime, Dr. Shahab, what resonated for me was a couple of the comments that you made was, number one, that real-time research is important and the difficulty of having real-time research. And I think that's always been the divide between research and practice, is that there's this very long delay before the findings of research can actually be implemented. So I think this is a really exciting, when you said that you were very impressed with how quickly researchers were able to pivot and find a new way to do that. I think that's the pandemic, as bad as it's been, has caused us to rethink a lot of things and how we do things and what we, and how we implement that. So I do appreciate those comments. While we're just waiting for some questions to come in here, can you tell us, just from a very practical point, what does your support team look like in terms of research? I know that there's a COVID rapid response team that's been a very important partnership between many people, but what does your day look like? Who's supporting you? I would hope you're not responsible for yourself for finding the best research and best evidence, but tell me a little bit about what your day looks like.
Yeah, thanks for that question. So again, so I was working in Yorkton, Saskatchewan when SARS came, and as you know, the internet was evolving, email was evolving. The bulk of correspondence was still by something called mail in 2003. And we actually looked at newspapers that came by print for the most part. So the Globe and Mail will announce case numbers on a daily basis. I think information flow now is astounding, both within the province and nationally and internationally, both in terms of epidemiology. I showed you a few dashboards that seem to be not government owned, but are just through people who are interested, universities and other partners, and research in real time, being, Lancet, New England Journal of Medicine, and then people aggregating that, the Public Health Agency, the University of Saskatchewan Science Review Group, the aggregation of research and the knowledge translation. So I think it's very hard, even for someone like me who would like to read more original articles, to really read everything, but what's the distilled findings of not just a single study, but an aggregate of studies has been really important. And then, many other partners in Canada, Public Health Ontario, Public Health Canada, BCCDC, they've also been distilling findings, the National Collaborating Centers on Environmental Health, Infectious Disease, about, for example, what's the transmission risk outdoors versus indoors, those kind of things. So I think reviewing that evidence and having that on tap has been critical to develop policies based on the evidence. And also it's been important that as that evidence changes, we adjust the policy. So again, in Southeast Asian countries, mask use has been high throughout. In Western European and North American countries, mask use was not high in February, March, but increasingly mask use has been recommended more and more. In the summer, with our low transmission rates and our the fact that we were spending a lot of time outdoors, mask use was not a strong recommendation. Now you can see that there's a mask mandate. So again, the same intervention, which is wearing a mask, as one layer based on both our local transmission and on emerging evidence that shows that actually masks, properly designed, reusable masks, 3-layer preferably, or at least 2-layer, can actually not just protect others from someone coughing droplets out, but can also protect you to some extent. And some intriguing hypotheses in a few studies showing that even if a mask, a non-medical mask, may not offer 100% protection, can reduce the inoculum dose to result in asymptomatic or less severe infections. So I think a lot of that real-time research has informed policy for Canada and Saskatchewan.
Good. Thank you. And we're going to the chat room here. I'm going to call upon first Michelle McCarran to ask a question, and then I think we'll go to Candace Scrappick. So again, please take a moment to introduce yourself, where you're from. And I think Michelle's question builds a little bit about where you were going with this question. So Michelle, hopefully you're unmuted, and then next will be Candace Scrappick.
Hi, Dr. Shahab. Thank you for that wonderful, informative presentation. I'm a member of the evidence review team and a research scientist with the SHA. And my question was, what are the biggest challenges that you have faced when going from taking those evidence reviews to implementing them into evidence-informed decisions?
Yeah, thanks for that question. I think the big thing right now is that, I don't know, that's being debated vigorously in the media, and some of it relates to evidence, but also knowledge translation, communication, and action. That what should be a recommendation that it's up to individuals to adopt. And as we know, physical distancing was a recommendation. What should be a guideline in our, for example, Reopen Saskatchewan guidelines, for example, that when you're in a grocery store, you have to maintain a 2-meter distance. There should ideally be engineering controls in place. And what should be an order? So, for example, through an order, there's now requirements for mask use in indoor public places. So I think you have good evidence. How do you apply that? Is it a policy thing, and then is it a provincial policy, or is it, for example, an SHA policy as it relates to healthcare facilities and long-term care facilities? What can remain a recommendation around having no gatherings in your home, or how can it be an order? So I think how do you apply research, I think, is important. And I think risk communication is important as well. So, the government of Saskatchewan and the SHA does send things out through social media platforms. And combating misinformation, I think, has been huge. We already saw over the last few years the challenge we had with vaccination, for example, around challenging miscommunication. But I think pandemic has been no exception in terms of the miscommunication. And well-meaning people get information that's wrong, and it takes a lot of time to then counter that with evidence-based, credible information. Thank you.
Thank you so much, Dr. Shahab.
All right, we have, honestly, Dr. Shahab, I knew there'd be lots of questions, but the chat box is filling up, so we will save those. And just even for your own interest, I'm sorry we can't get to all of them today, but we will go to Candace Scrappick next. And hopefully we can have time to squeeze in one more question. We have a couple comments coming in regarding long-term care, but we'll go to Candace first. And if we have time, we'll segue into Aisha Saeed regarding long-term care. We've got a couple questions there. So Candace?
Great. Thank you, Elan, and thank you, Dr. Shahab, for your leadership and your steadying influence. I know that evidence-based decisions about public health is going to be key to eventual control. I'm a patient partner with SCPOR and a longtime volunteer with the Saskatoon Council on Aging. My interest is particularly around issues that affect older people. And the COVID-19 pandemic has had a profound impact on the health and well-being of older people in Saskatchewan. But it has also given rise to a series of critical policy questions surrounding how we view older adults, how we should support them, and how we engage a diverse aging population into the future. As we look beyond the COVID-19 pandemic and research is carried out to examine the pandemic response, how do we ensure that the voices of older adults are heard in that research, that the diversity and perspectives of older adults is reflected in government public policy, and how older people are engaged as co-leaders in developing new and innovative approaches that impact them directly?
I think you brought up some really important areas, and I won't go into detail on answering them. And again, these are, answers to these should be sought from individuals who belong to that demographic, as well as policymakers whose policies have an impact. But I think those are really critical points, whether it's how therapeutic and vaccine trials are done, how people who are older are better protected within society, but in a way that also maintains quality of life issues. And we saw the tremendous impact of isolation in long-term care, personal care homes, when visitation is significantly curtailed, but obviously, that's done to prevent the risk of outbreaks. So I think that those are important questions. And certainly, I think pandemic has brought that into sharp focus, as well as some of the equity issues for others who may be working more frontline and, for example, may not be able to work from home for long periods. But I think those are all excellent points about how policy informs the general population, but looks after the interests, and not just interests in terms of protecting from COVID or other issues, but also their general well-being from all aspects. I think there's a really important points. And again, if there's a table that looks at these, obviously people like myself and others would be extremely interested in participating going forward. Thank you. But thank you for highlighting that in such a comprehensive way.
Great. Well, unfortunately, our time has ended here, and just so many questions, Dr. Shahab. We wish we could have stolen you away for the entire morning here. Maybe you're not, you need a little bit of a break, but I hope this was a bit of a reprieve to your daily routine here, and that you enjoyed interacting with the research community and our patient partners. But I have learned how to, I'm not techie, but I have learned to do this, put hand claps in the corner. So on behalf of the Research Showcase Steering Committee, and on behalf of everybody here today, thank you so much for taking time out and sharing your, oh, look at all the claps coming up. I thought I just had really discovered something quite clever here, but apparently not, and I'm okay with that. But thank you again, and enjoy the rest of your day, and thanks again for sharing.
Thank you very much. And it's a pleasure to be here.
Great, thank you. Everyone else, we're going to segue immediately into our COVID Saskatchewan snapshot.